we've been doing this journey through the body with the torso, and then we looked at the lower limb, and now we're looking at the upper limb. And the limbs attach to the torso. So the anatomy and how you think about massaging the torso, including the head and neck, is a little bit different than massage of the limbs. The limbs don't have any vital organs. You can get rid of all your limbs and you can still be alive. So the arms and legs are very similar. But because we stand on 2 feet, it frees up our arms, and so our arms have adapted for more mobility and ability to reach and grasp and all of that. So there's less weight bearing that happens in the upper limb than it does in the lower limb. The upper limb is more mobile. And so for massage therapists, however, because of the way that we stabilize to apply pressure, we start to make the upper limb almost like the lower limb in terms of how do we provide stability and situate ourselves. And what a trend has been that people, body workers, massage therapists have started doing, you've seen it, the massage with your foot kind of a thing. The issue that comes with that is the idea of, if you're going to use your feet, then you've got to stabilize on one leg. When we teach you to do that, we teach you to use a cane or something. Or you've seen people hang from bars, which does then open up the feet so that you can use them, and then you're weight bearing on your arms, and so that is not necessarily the best idea either. So massage therapists end up with a lot of problems in their upper girdle, their shoulders, and it'll translate up into the neck. How many of you have at one time had something going on with your elbow, shoulder? Wrist. Yeah. And so for us, it's really important that we learn the balance between stability and mobility, and a lot of it has to do with stability. And in our introduction, before we started the recording, we talked a little bit about the importance of ergonomics and body mechanics and that sort of thing. So this one then is going to take a lot of the same methodology, but we're going to focus it in this upper girdle arena. And I am going to introduce you to a couple of other bodywork concepts. One of them being direct and indirect functional technique. And I mentioned that when I was talking about what one of our future classes was going to be. So then we also have to start to take a look at the neurological reflex connection between the upper and lower limb and the girdles. The girdles are where it attaches to the torso, because there's a constant interaction related to balance and counterbalance when we walk. So that's kind of what we've got in play here. So here's a fun little picture that just gives you some reference points. So we have extrinsic, if you recall, where the soft tissue structures connect to different locations in the body. So these structures that are on this side over here, they're attaching to the torso and then into a limb. And then we have intrinsic muscle structures that are isolated just to the area. So this group right here, layered underneath the extrinsic muscles, structures, is that particular group is about shoulder mobility and trying to keep the arm in the ball and socket joint. So it's it has to function with mobility and stability, and so you hear a lot of people say they have rotator cuff muscle problems, or they've hurt their rotator cuff. For massage therapists, maintaining stability in this area is really important. And we rely on a lot of our extrinsic muscles to do that. The position of the scapula and how it moves, because it has to move to allow for the full range of the shoulder, also is dependent upon deeper muscle layers, the rhomboids and the anterior serratus, and then the levator scapula there. And so many times people think they have a shoulder problem, but what they really have is a scapular issue. So that's one of the places that we'll look a lot at when we think about application and methods. So this particular view here gives you just a little bit of a perspective. This is the posterior side. This is the anterior side. So you should be looking at it from this view, and then this is this part, and back here is this part right here. And you can see how the various muscle structures, and this isn't very accurate in the sense that it's all the connective tissue and the layers of tendons and ligaments and all that goes in, but it does give you some perspective around this ball and socket joint. So this ball and socket joint is multiplanar. It means it's flexion, extension, abduction, adduction, internal rotation, external rotation, and all of them together. So we have that at the hip, but the form of the ball and the socket is much deeper at the hip, and here at the shoulder it's really shallow. So this little structure here called the labrum tries to make that socket a little bit deeper. But have you heard somebody say they tore their labrum? Mm-hmm. Yeah. So, and then lots of times the pain that occurs from that is it gets pinched. That structure gets pinched every time you move things around in there. So, most of the muscle, or all, I would venture to say, all the muscles in here have multiple purposes. And they have to navigate this mobility stability issue because they're called on to do both, sometimes at the same time. And the body tries to favor stability. So things will tighten up, shorten up, so that your arm doesn't fall off, which is a bit of an exaggeration. But then people will, have limits in their mobility. So when we're looking at the ball and socket itself, the range of flexion and around through to extension is about 90 degrees. Once it goes higher than that, it's all about the scapula. So somebody says they have frozen shoulder, they can't lift their arm up over their head, some of these tests that go on, and we concentrate on the arm or the shoulder proper and don't stop and think about, is that scapula? Well, Logan!
Oh boy, great interest, huh?
Oh, I'm so happy to see your little self. Introduce yourself, Logan.
Logan.
Logan started school as a baby.
Not there at all.
And he said he's one of the teachers, so that's cool too. All right, so this picture, you can see, layer. Up here where the deltoid is at, it's pretty thin, but there are muscles that come in around that. The supraspinatus is one of them. And then the thickness that is in this area that we think of with the armpit, the posterior part of the axilla. This picture here of the deeper layers, this is subscapularis, which is very confusing to people because it's actually, this would be the posterior view. It's on the inside. So it lays like this. And so in order to get to that, which is part of the rotation and part of the stability, we have to have a journey, kind of through the axilla to be able to apply some inhibitory pressure in through here. So we need to be aware of how often we're digging around with somebody's armpit with shoulder issues or nerve impingements that will travel down the arm and make for the pain of a nerve impingement is usually hot and people draw a line on it and that sort of thing. Thoracic outlet syndrome, while primarily a trunk issue, that's where the brachial plexus coming out of the cervical vertebrae comes down and into the arm and here into the front of the shoulder and behind the shoulder blade. A common place for impingement of that brachial plexus is here at the clavicle, and understanding the acromioclavicular joint and the sternoclavicular joint and the movement of the clavicle. So we're working at multiple depths. And how do you get from a fairly thick surface muscle structure down to something that is smaller? How do you get through it without damaging the tissue or causing undue discomfort? That's one of the tricks. When we move down the arm, then it starts to simplify in terms of function. The elbow is primarily a hinge joint, which means it just functions in flexion and extension. It doesn't have all these different movements that go with it. One of the things we have to consider now are muscle structures that cross one joint and muscle structures that cross two joints. So the bicep crosses two joints. So it can function in flexion and a little bit into the rotations a little bit because how it's oriented, and also is a major elbow flexor. So it can do either one. That makes the whole function more complicated. So the terminology for origin and insertion is weird for muscles. A better descriptor based on location would be proximal and distal. Proximal closer to the torso, distal further away. That doesn't change. But with two jointed muscles, if you're looking at it in terms of origin and insertion terminology or nomenclature, the origin is the fixed attachment and the insertion is the more mobile attachment. So in a two-jointed muscle, if I am using the biceps as part of a flexion, then that is the insertion, and the origin is down here. But if I'm using that muscle primarily as an elbow flexor, now this is the origin, and this is the insertion. So, some of you are preparing for, or will be preparing for the MLEX exam, and there's confusion about the terminology then related to that. They use both proximal and distal attachment and origin and insertion. So in your brain for that exam, you have to go probably when they're saying origin, they mean proximal attachment. And when they are saying insertion, they're meaning distal attachment. But that's not accurate when you're looking at function. So the terminology is always a little bit of a struggle, and it makes that terminology, those nuances in terminology, make a lot of things difficult when English isn't your first language. You know, and how are you thinking about when a person, like on the MBLEX, they're writing a question, you know, they're going to go with what they learned, you know, and not necessarily, and the anatomists have been trying to change this language to proximal and distal for years and years and years, and it persists with this confusion around origin and insertion. So you got to learn both, you know, and the nuances of both. Ilian would get after me or give me a look that says, I have no idea what you just talked about. When I would talk too fast, or I would use jargon or slang or something like that. And it's really difficult when you've got 5 names for the same thing. Joints are like that too. You can name them as, you know, synovial and fibrous, or you can call them diarthrotic, and you know, there's a lot of names that unless you go, okay, this is all the different ways these structures can be named, and then somebody uses a term, you know, it can get kind of like, I really don't think I'm following what's going on with this. But we do have a set of 2-jointed and 1-jointed muscles that we can talk about. So I mentioned the biceps, but this is the brachialis, and it's a 1-jointed muscle. So it's the one that is mechanically oriented on the body for the most strength in flexion. And so I think that we get a little, you know, make the Popeye muscle and that sort of thing. You bring it up like this and do this, you're activating the biceps, but in the general, and the brachialis, but in our general function with what we're doing, we're really need to take a look at the brachialis, because not only is this where we get our most power with our movement, it's most oriented for elbow stability. And it also provides some counteraction for our supination and our pronation. So that's really important for massage therapists, because we need to work with our elbows stable. And I see a lot of people working, using the palm of their hand, but their elbow is bent. And that is going to really strain that. Another place that people, they don't think of the tricep as a muscle that attaches to the scapula. But three heads, proximal or the distal attachment, they all kind of come in together. But as it moves more proximal, you end up with 3 different attachment points. And this one goes way up into the scapula. And Luke experienced this, where he struggled with something in there, right? And I finally went in there and addressed it off of the tricep. So this becomes interesting, because one of our main interventions is inhibitory pressure, put pressure on the spot, and then move it. So I have to, if I'm gonna try to address the attachment of the tricep on the scapula, and then I want them to move it, I gotta think about extension, because that's what's gonna activate the tricep. Our brain wants to tell us to do flexion, or rotation. So it does become important when you realize what a particular muscle is positioned to do. So that's an area to make note of, is that you're going to want, if somebody has got something in their armpit that they can't quite put their, they can't quite get over, it kind of lingers, you want to check and see what's going on with the tricep. So that's just the general overview of the anatomy. When you're studying anatomy, I like to encourage you to just stare at things. Once you pass the MLEX, it's less about individual muscles and more about group function. How does if I'm working at the elbow here and I flex, these are the prime movers, but that's not going to occur if I don't have coordination with the opposite muscle group. So everything operates in a pattern, and you can't separate it. You can't just work in one area. If I'm going to work here, then I also have to work here. If I'm going to work here, then I also have to work here. You got to do both sides of it, and you got to understand the function. So muscles can only pull, and then they sort of kind of then can let go. So when I'm making this action, this group in through here are the primary muscles exerting the force. They're shortening so that I can lift, I can pull, I can lift this up. This group over here, back here, this is a concentric action. This is an eccentric action. It's still under tension, but it's very controlled, getting longer and longer and longer. Otherwise, you can't, once you get it into position, they switch roles. This now is functioning concentrically and pulling. And this has to function eccentrically and let go. And that neurologically, that can get disturbed, especially if somebody has held a contraction for a long time in a particular area. So you want to, if you're doing exercise or something, you need to exercise through the full range and not, this isn't going to do it. It's got to be through the full range. All right, so when so once we got this general idea of muscle, connective tissue, neurological, idea of what's going on, then when we are trying to interact to improve function or reduce pain or make things work more coordinated, these then become what are accurately termed interventions. So when we're doing massage, we're working with assessment. How you doing? Are you moving very good? That assessment can be palpation, it can be active joint movement, passive joint movement, resisted with some muscle testing. And we want to do that as part of the general massage. So if I'm working on the upper limb, I'm gonna, rhythmically move it through all of its range. And if I don't find anything, if the person doesn't have a symptom in the area, like when I did that movement right there, I felt it right there. So that's a symptom. then I might narrow down on that to see if I can figure out why that is occurring. But if there's nothing that shows up with it, range of motion is fine and all of that, then you move on. You don't try to change what's not broke. The general massage, what we do with the various pressures and the movement and going with the grain, with the grain, across the grain, as we're moving those tissues around, it generally supports compartment sliding and generally improves fluid movement and reminds the muscle groups how they're supposed to cooperate with each other and all of that. So you're going to get a general, it's like dusting, you know. You're not changing anything, but you might pick something up and put it back down, you know, or whatever, or not, if you dust like I do. But generally supporting the most optimal function and well-being that a person has at the time. But that also is our assessment, particularly if somebody comes in and has an issue. So, when we decide to work on something to see if we can improve the function, now we're doing an intervention. So when you're doing full body general massage, Ben mentioned earlier the importance of wellness and relaxation, because that's the foundation of everything. In that context, we add in our interventions. And so if you were looking at the standard 45, 50 minute thing, only about 5, maximum 10 minutes of that whole thing would be intervention oriented. The rest of it would be your general massage outcomes, which is assessment. So my group that started in the fall, we're getting right ready to shift the mindset from general protocol. I move from this spot to this spot to this spot, and my body mechanics are like this, and I can put the pillow here, and the drape fell off, but I can get it back on pretty quick, you know, all that kind of stuff. To, okay, you can do a massage. Now you need to pay attention. What do you feel? What's going on? How does it, you know, when I move from one area to another, if I use some pressure that recreates a symptom in the arm, do I see anything compensating in the rest of the body?
Pattern recognition.
Yeah, absolutely, pattern recognition. And you're not going to get good at that until you don't have to think about everything that goes on with the general massage. And this, in general, is a big miss in massage therapy education, that it is not reinforced how important it is to be able to do, without having to think about every single piece of it, a full body general massage in multiple positions. And varying your pressures in a way that you can assess for tissues that are more surface and tissues that are more deep. And that you can use your palpation now to discern stiffness, or which would be kind of a connective tissue thing, or bogginess, which would be more of a fluid thing, and where things are not sliding like they're supposed to. That is not going to occur efficiently if you can't do a full body general massage in all positions without having to think about every single move. And I get frustrated when, okay, we're going to teach you how to do a general massage, and sometimes they'll call that a Swedish massage, you know, that's relaxation. Okay, now we're going to teach you trigger point. Now we're going to teach you, Yeah, and none of that, think about this when you're doing continuing education other places too. These are all interventions. You hope you don't have to do any of them. You hope that the person's body is functioning with a solid well-being, and everything is sliding and all that, and you're just going in and reinforcing all of that. These are not special, unique, or fancy, or whatever, but what's happened in the massage world is, in its attempt for us to feel special, like we gotta, a lot of massage therapists are physical therapists wannabes. And they're not aware of how important what we do is. Because we're the only ones that sift through it all. You go to an osteopath or a chiropractor or whatever, they're gonna narrow right in on a symptom, and then they're gonna try to reverse that or fix it, find and fix. The find and fix mentality is really flawed. Especially when you start to realize that everything is connected to everything, and if there's a shoulder thing, there's probably a hip thing. And if there's a hip thing, there's probably a knee thing. And the nice thing about massages is the general massage, where you sift through all the tissue, move all the joints through the range, all that kind of stuff, and how pretty and fluid and relaxing you can do that. That's where the skill set is. And so then you only would intervene if you felt that the person has the adaptive capacity to do that. So using my shoulder thing, since I just fell on it not too long ago, it's in its last stages of subacute healing. I jammed it when I fell. I caught it, kind of a thing. And it's progressing. We're built to heal. We know how to heal. So when we're looking at stuff like this, if it's in the acute phase, leave it alone. It's doing its thing. Work on everything else that might be compensating. So I recall holding my arm closer to my body, so that I could stabilize whatever I did up there, And so I did get a little short in through here because I was in a protective mode with that. So I've had to do some reversing of that compensation. So in the continuing education model, you go in and you're going to learn this and you're going to learn that, but you never learn it in context. In professional practice, when you're doing stuff on a regular basis, you got to figure out how to be efficient. And so you start to work with pattern recognition, and you got to gauge. You got to make sure that you don't jump too quick to a conclusion, because it may not be a pattern that you're used to, but most of the time it fits. And then people sometimes then they shift away from the full body massage and see that little approach as an intervention. They start to see it as the whole thing. And I don't know, those of you that have been out there a long time, people aren't coming in general for interventions. They're coming in for a massage.
Stress relief.
Yeah. Can anybody give me a different approach on that? They want you to help them, but they don't want you to just poke on here and move that and they want whatever you're going to do. They want their massage, because if it's all said and done, you're really honest about it, the general massage is probably what made the difference anyway. Even with the professional athletes I worked with for so many years, people will get into this fancy stretching and or use of a tool, or and I remember one character said, you're the only person that I come to that actually puts their hands on me anymore. You know, they're putting a Theragun on, or they're scraping me with something, or they're, and I will use those things, especially if it makes working on a small area more effective. And here's the caveat, it's always gotta be easier on me. If it makes my life easier, then I'll incorporate it. Otherwise, it's like I mentioned, one of our C's is gonna be this decompression, this suction. And I think that there are applications of that are more effective, because if you're gonna decompress, you gotta lift and pull. It's much easier to just lean and press, but if I gotta lift and pull, that takes a lot more energy. So use of a tool to help you do that, I think there's value. I'm not a fan of the scraping. I think there's too much potential for injury. And I think people get too aggressive and all that kind of stuff with it. So anyway, we'll take a look at these little interventions, and we have the same time constraint that any other continuing education program has. So I always want to remind you that these are things you would use for a minute in the context of don't clutter the massage up. And the more you can sneak these things in so they feel like massage and you get the effect, the more mastery you have obtained. Now, when you're initially learning, these are, it's like having a whole bunch of tools. But over time, you should be able to seamlessly move from one thing to another, and unless the person that you are working with will feel the difference. But if somebody's watching you, it should be very boring. I see people, on YouTube, watch some YouTube videos, and they're flailing around and they're moving, and then they got this, and then they got this leg up like this, and they're down there and they're working like this because the table's too low, and and I will say, providing massage should not be an aerobic exercise. It is physical, but if you're, unless you're having a hot flash, if you're breaking a big old sweat, you need to figure out how to be more efficient with stuff. Don't overuse your hands, and things like that. So if you look at some of the videos I've done or the demos, I'm really boring. Really, it does not look fancy. So if you look way too fancy, you might want to go, do I really need to do that? Do I really need to have these long flowing strokes? Do I really need to lift under the body? Do I really need to do that? Is there a more efficient and effective way that I can achieve this goal and make it easy on myself? And I mentioned already, the vulnerability for injury for massage therapists is common in this area, especially when they overuse their hands.